I think we've done about 5 topics. So maybe if we do 2 or 3 more, that should be okay. Then I can give the rest to you as presentation topics.
Hey.
I think that's what we'll do. Okay, so we're supposed to do severe acute malnutrition today, marasmus and kwashiorkor, but I need to edit the notes a bit. I even owe you plenty notes. Don't worry, I'll sort you out. I'll sort you out this weekend. This weekend is all yours. Okay, so renal. So the kidneys lie in the retroperitoneal space, meaning the space behind the peritoneal cavity, slightly above the level of the umbilicus. And if you take the kidney in a newborn, it's about 6 centimeters and 24 grams. And it grows to the
Time
size
to go
of
out.
150 grams in an adult. And you know that it has an outer layer, which is the cortex, then the inner layer is the medulla. When you take the blood supply, you have the main renal artery, and then it branches into segmental arteries, interlobar arteries, arcuate arteries, and interlobular arteries. And this is what gives rise to the afferent arteriole of the glomeruli. And then we have the efferent arteriole, which leaves the glomeruli. So this is basically what I was trying to explain. The renal vein, the renal artery, those are the main blood supply to the kidneys. And then they branch sequentially into the various branches, the arcuate artery, interlobar, interlobular, and all that. If you look at the anatomy of the kidney in terms of the proximal tubules and the loop of Henle and all that, the kidney is divided into two anatomically. We have the outer, which is the cortex, and the inner zone, which is the medulla. Now, if you look at the medulla, you see that the medulla contains the collecting duct. It also contains the loop Henle. Then the cortex contains the proximal convoluted tubule and then the distal convoluted tubule. So the kidney's functional unit is a nephron. And if you look at the nephron closely, okay, if you look at the nephron closely, the nephron comprises of the glomerulus, which is where you have the afferent and efferent arterioles. Then you have the proximal convoluted tubule. The loop of Henle is the U-shaped tube. Continuation of that is the distal convoluted tubule. And then it's connected to the collecting duct. When urine is formed, it goes to the collecting duct and then it is excreted. So if you look microscopically at the kidney, each kidney contains about 1 million nephrons. And the nephron is the unit or the smallest functional unit of the kidney. And the number of nephrons ranges from 200,000. And this variation or the difference from 200,000 to 2 million can have a significance in terms of risk factor for later development of renal dysfunction and hypertension. So if you have a small number of nephrons, then you are at increased risk compared to somebody with a larger number of nephrons. And biologically, that is in utero, the nephrons are completely formed by 36 to 34 weeks of gestation. So that should tell you that if a baby is premature before 36 weeks, then this baby would have a very high likelihood of renal immaturity. And the functional maturation, that is how the nephrons mature, and then the fact that they become longer continues throughout from birth till about the first decade of life. That's about 10 years of age. And because new nephrons cannot be formed after birth, any disease that leads to the loss of nephrons can lead to renal failure or renal insufficiency because the kidneys are not regenerating themselves. So if you have a problem that destroys your kidneys, then that's it. It means that you are heading for renal insufficiency, and the only thing that can help is a replacement, that is by transplant or dialysis. So you can also have a decreased number of nephrons due to low birth weight or prematurity. Like I said earlier, the maturation is completed by 36 to 40 weeks of gestation. So preterms at increased risk of immature nephrons. And this is a risk factor for the development of hypertension and progressive renal dysfunction. The low nephron number leads to increased filtration in the small number, leading to overworking of the small number of nephrons. So people who have smaller number of nephrons are at risk of getting hypertension as a result of the fact that the small number of nephrons are overworked to clean the blood of toxic substances. So we look at histology. So histology means we are going to the cellular level. So at the cellular level, when you look at the glomerular network, it is a network of specialized capillaries, and it's like a sieve. It forms the filtering mechanism of the kidney. The capillaries are lined by endothelial cells, which have tiny holes in them called fenestrations. Like I said earlier, it's like a sieve. So the holes in the sieve are called fenestrations. Then you also have a glomerular basement membrane, which forms a continuous layer. And this membrane has three lamina densa, the lamina rara interna, and then the externa. And when you look at the epithelial cells, they have what we call foot processes, which are attached to the glomerular basement membrane. So if you look at it under the electron microscope, you see three layers. So the first layer is where you have the CAP. The second layer is where those are the foot processes. And so the filtrate or the blood goes through these layers and is filtered. So substances which are useful are returned to the blood, and the ones that are not useful will go through and be filtered as urine. So between the foot processes, you have filtration slits, and then you have the Bowman's capsule, which is like a cup surrounding the glomerulus. And this is where, when the filtration occurs, it goes through the Bowman's capsule. Okay, so this is the diagram of the glomerulus. You see the afferent arteriole and the efferent arterioles. The afferent arteriole has a bigger diameter compared to the efferent arteriole. So what is like, you have water coming through a pipe, a large pipe. Then it gets through the network of the glomerulus. And then when it's leaving, it leaves through a very small aperture. What this means is that the water comes in at a high pressure, but because the exit is very small, there will be a lot of pressure built in the glomerulus. And this is what leads to the ultrafiltration, whereby the blood is filtered and then the waste substances come out in the Bowman's capsule to form the urine. So let's look at physiology. So as the blood passes through the glomerular capillaries that we just looked at, the plasma will be filtered. And like I said, it's like a sieve. So this ultrafiltrate, which is filtered through the sieve, is cell-free. The holes are big enough to keep the cells. So the cells will stay, and then the ultrafiltrate will come out. And this ultrafiltrate contains all the substances in the plasma. So peptides and then proteins which are of low molecular weight. So when it collects, the filtrate will collect in the Bowman's space, and then it goes into the tubules, the proximal convoluted tubule and the distal convoluted tubule. And in these two tubules plus the loop of Henle, solutes are added or taken out, and then finally it leaves the kidney as urine through the collecting duct. Okay, so basically, this is a diagram of the filtration process. So it's like a plant. The fluid, the blood will enter through the afferent arteriole, and then it undergoes ultrafiltration. The ultrafiltrate comes out through the Bowman's capsule. So following the arrows, it goes to the proximal convoluted tubule, where you have these blood vessels surrounding the proximal convoluted tubule. So some substances are secreted into the blood, whilst others are also added to the urine, to the ultrafiltrate. Then it goes to the loop of Henle. From the loop of Henle, it goes to the distal convoluted tubule. So the final byproduct, or the final product, which is the urine, goes through the collecting duct, and then it collects as urine. So if you look at the glomerular filtration, what happens is that some substances will be filtered while some will remain in the blood. And this is because of opposing forces across the capillary wall. So the negatively charged proteins will be repelled by the negatively charged proteins in the glomerulus, and so they will not be filtered. They would rather stay in the blood. And this is what leads to the filtration. Now, also, proteins which are larger than the size of albumin are absent from the glomerular filtrate because the holes in the glomerular basement membrane are of a particular size. So they don't allow larger proteins to filter through. And like I said, most of the substances which are not filtered are because of their size and their ionic charge. So they are negatively charged proteins. So anything that is negatively charged will not be filtered. Then also the filtration allows certain size of protein. So any size of protein which is higher kilodaltons. Okay. So yes, the negative charges would repel. All right. So if you look at typically what relates to pediatrics, the glomerular filtration begins in utero inside the womb at 6 weeks of fetal life. But the kidney is not functional because the waste substances are taken care of by the placenta. And so kidney function is not necessary for normal intrauterine homeostasis. So the pregnancy can go on all right, even if the kidney is not working well, because the placenta serves as a major fetal excretory organ. The glomerular filtration rate in the newborn infant is low. And at 28 weeks, especially in the preterms, at 28 weeks, it's just about 10% of that of a term infant. But this is not a problem because, like I said, you don't need the kidney to function in utero because the placenta does that. But when the baby comes to 10, it rises from 15 to 20 to about 80 to 120 within the first 3 years of life. So the glomerular filtration rate is very low in infants, but as they grow, it increases. And after birth, it increases till about 18 to 20 years, by which time the kidneys stop growing. So usually, the glomerular filtration rate of the child does not get to the adult value until the 3rd year of life. So this is just to demonstrate the change in glomerular filtration rate as the child grows. So like I said, from birth, it is very low, but it grows till about 3 years when it approximates that of the adults. So when we want to measure renal function, how do we do it? Renal function is measured by the serum creatinine level. So we know that if you want to check the kidney function, you request kidney function test. And this is the blood urea nitrogen, and then what is measured is the serum creatinine level. We know that creatinine is derived from muscle metabolism, and its production is relatively constant. And it is excreted mainly through the kidney by glomerular filtration. So in situations where you have a problem with the kidney function, you'd realize that the serum creatinine level will go up because it is not well excreted by the defective kidney. Also, we measure blood urea nitrogen level, which is affected by the state of hydration of the body. So if the patient is dehydrated, you realize that the blood urea nitrogen goes up. Okay. So because the level does not rise above, sorry, please give me a minute. Sorry. So we would usually use the serum creatinine to estimate the glomerular filtration rate in the steady state. What this means is that a patient can have a normal creatinine level without effective renal function. And this can occur during the period that the renal function is normal, just before they get acute renal failure with absence of urine. And so in this case, the serum creatinine may not really be a sensitive marker because the kidney function will have to go down drastically before it will be picked up in the measurement of the serum creatinine level. So how do we estimate the eGFR in pediatrics? This is done using a formula called the Schwartz Formula, and it is based on the height of the patient and then a constant. The constant depends on the age of the patient. So, so if you want to measure the GFR, which is a measure of the function of the kidney, it is the constant times the height divided by the serum creatinine. So that's why you need your BUE creatinine. So the constant is 0.33 in premature infants, 0.45 for infants, 0.70 for pubertal males, and 0.55 for all other children. So this is how you calculate the eGFR in pediatrics. So let me give an example. So let's say you check a child's BUE creatinine, and the creatinine is let's say 100. So to check the EGFR of the child, and let's say the child is 100 centimeters as well. 100 centimeters would be 1 meter. So to calculate the EGFR, it's a constant. So let's say it's a pubertal male, a 12-year-old. So 0.7, which is a constant, times the height, 1 meter, divided by the serum creatinine of 100. That is what will give you the estimated glomerular filtration rate. And depending on what you get, you can check from the charts and decide whether this renal function is normal, whether it's abnormal, whether it is end-stage renal failure or whatever. Please, are there any questions? Any questions?
Yes. Oh, good evening.
Good evening.
It made mention that during the ultrafiltration, some of the particles, if I can say, are too large to go through the, let's say, the podocyte. So they are not able to go through, the ultrafiltration to join the blood. What happened to them?
So they get in the blood. So, okay, so let me say that we are filtering the blood. Basically, that's what happens. So you have the blood entering from the efferent arteriole into the glomerulus. Okay, yes. So they enter through the blood vessel. Now, the podocyte is what is showing. And so if you have the filtration occurring, the ones which are too large to go through will stay in the blood. It's like you're sieving what? Let's say palm nut soup. Yes. You pour the chaff plus the juice or whatever it is through the sieve. Now the chaff will remain in the sieve, and the juice that will come through would be minus the chaff. Now, in this case, in the case of the glomerulus, the filtrate, the ultrafiltrate that comes through the glomerulus, which is the sieve, is actually what will become the urine. I hope you get it.
Yes, please.
So the useful substances are retained in the blood. The large molecular weight proteins, the albumin, all those negatively charged proteins, they stay in the blood. Then the substances which are not necessary, like maybe excess sodium or too much water, will now be filtered out, and they would rather end up as the urine to be excreted.
No.
Hello, madam.
Yes.
Please, I want to find out when you're doing a creatinine test, you realize that when you check the results, like a regular test result, you realize that there are different categories, like in terms of the reference range. There's a reference ranging for males, there's a reference ranging for females, and then there's a reference range for even neonates, infants, neonates, and everything. Madam, I want to find out why is that I say disparity.
Why that's so? Why that's so?
It's my friend.
Creatinine is for metabolism of muscle. So the amount of creatinine, the amount of creatinine that you have is a function of how much muscle mass you have. Because the creatinine is a byproduct of muscle metabolism. I hope you appreciate that.
Yes, please.
An infant will have a smaller muscle mass compared to an adult. And also, when you compare the sexes, males are more muscular than females.
Females,
and
okay.
So the reference range for a male will be different from the reference range.
Okay.
All right.
So Okay, so then that means that allows the calculation of the EGF very obvious.
Yes. So that's the formula that I showed you, the Schwartz formula. So even in pediatrics, the reference ranges are different, or the EGFR will be different. Hey, who is that?
I've muted him, Doc. Don't worry.
Okay, so the reference ranges will be different for the pediatrics
category
for the elderly.
Yes.
Okay, Madam, please, I have a question relating to this one.
Okay.
So if you have a patient who is very muscular, like Renal, and then
Renal, are you muscular? Okay, well.
Madam,
we have 8 minutes more. So
have someone muscular, who has relatively smaller muscles.
Pardon?
Like someone who has relatively smaller muscles, like cola. So in that case, are you saying that Ronald's reference rate are going to be higher than that of
So ideally it should be so, but then the reference rate is not based on the muscle mass of the male. Okay, so the reference range is different for males, all males, but of course it is the same for all males. But there will be disparity. So, for example, if you do the calculation, depending on the amount of muscle mass a person will have, the interpretation might be different. Okay. That is why sometimes when you do a lab test, it's best for you to take it back to the one who requested it for the interpretation. Sometimes you can go and do a lab test, but then the interpretation will be different, even though it looks like it's out of the reference range. Because these are some of the small peculiarities that pertains to the unique individual. But the reference range is the same for males, it's the same for females.
Okay, thank you.
All right.
Okay, madam.
Yes.
We are saying creatinine is a muscle byproduct of muscle mass or whatever. What about urea?
Muscle metabolism.
What is the for the urea? I want to know why urea 2 is part of the kidney test.
Okay, so urea is as a result of protein metabolism. Okay. And protein, when you metabolize protein, you produce anemia and urea, and it's excreted by the kidneys. So that's why it's part of the kidney function test. If you are not able to excrete the urea, then it will build up, and actually urea is a more sensitive test of kidney problem than the creatinine. So if you have a patient who is undergoing dialysis, for example, the urea is what is used to detect whether the dialysis is working well or not.
Okay, so ideally the urea is supposed to be excreted in the urine.
Yes.
Okay.
Any other questions?
Nick, I have a question now. No, I debate that.
Any questions? I bet you were class.
When I see you, I'll run.
Any other questions?
I don't think there's any other question.
Okay.
But madam, the notes are bunch. Run
So
the slides.
You see, when the notes are plenty, the questions are easier. When the
Hey.
notes are small, then the questions are difficult to read.
Doc, which mathematical feature is that?
Madam,
It's my
here's the
own,
case. Here's the case. Here's the case we are not able to go through all, because I think you have to go some of the slides you read over and over before you'll be able to capture.
Madam,
Something like a developmental growth like this. The understanding is not easy like that. So we have to go over and over and over and over and over again.
But listen,
So
if you have children or nieces and nephews, that's the easiest way to learn the thing.
And Doc, this one that we don't have.
Yeah, no,
It means we are condemned. It means we are condemned.
Madam, I want to ask a question. I saw something somewhere about testing in terms of like clinical diagnosis. They are saying that it's good to do a pre-test probability before you even request for a test. Like you should like in terms of when you're about to take order a test based on your diagnosis, you should actually do a probability testing. Like, let's say, looking at the condition, you should rethink about it very well before you actually order the test, because sometimes some of the tests you wouldn't want to be faced with issues like false positives and then false negatives before you even.
So it's not like you have to do the probability test, you should know it.
Okay.
You should know it. So for example, if you request a malaria test, RDT, what is the false negative rate? What is the false positive rate? Is it worth doing it? Is it worth requesting? Do you get it?
Okay. Okay.
So you know that already. It's the way you said it, it made me think as if you have to go and conduct
do that. No.
So you should be aware, and that is why you do public health and you do probability and all those things. You should be aware that okay, this test has a 95% sensitivity rate. What does it mean? It has a 98% specificity. What does it mean? So if I request the test and it comes out positive, what is the chance that this patient really has the disease? If I request the test and it's negative, what is the chance that this patient does not have the disease? You see, so when you know this, then you can decide if there's even any use doing the test. Okay. And then you don't waste your time and waste the patient's money to request the test that has a low sensitivity or a low specificity.
Sensitivity. Okay. Then you can go ahead and actually give the treatment.
So that is what you should know before you see the patient. And sometimes the patient can come and tell you that why treating malaria when you haven't tested me for it?
Yeah, they always ask this question.
That knowledge, pardon?
They always ask this question. People do say that
based on
the doctor
your knowledge, you explain to them that okay, this test has a very low sensitivity, and so even if it comes negative, I might still go ahead and treat because of your symptoms and the fact that even with these symptoms, there's a likelihood that you will still test negative.
Okay. Thank you.
So you have a lot to learn.
Serious. Serious.
Don't worry, it shall be well.
Understanding the patient. That is where the problem is.
Yes, sometimes some patients may come and they're not there to look for labs, so they want treatment. Some patients too will come, they want you to do all the labs before you
all the labs, exactly.
Be able to tell which is which so that you please them, and that starts by building rapport and chatting about the consultation before you even progress to ask what is wrong with the child.
Okay.
You see, somebody might pass a comment like, oh, we went to another hospital, they didn't even request for any lab.
And then they see the doctors